You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is June 4th, 2012, and I'm your host, Dr. J. Portpoint. Our topic today, primary immunodeficiency. Our presenter is Dr. Christina Ciaccio. She's in the section of Allergy, Asthma, and Immunology at Children's Mercy Hospitals and Clinics.
Dr. Ciaccio.
All right. So today we're going to talk about primary immune deficiency, and the idea is to try and take what we've learned from the Avast text this year and apply it to understanding where these primary immune deficiencies come from. I'm not going to have time to do a secondary immune deficiency talk this year. I did it last year. I'll do it next year, but I think the primary immune deficiencies will take up most of the time for today. Okay. So the principal consequence, I think that's spelled wrong. Principals, Pam. I think that's the guy who's in charge of the school.
All right.
All right. The principal consequence of immune deficiency is an increased susceptibility to infection. So this is always the first thing that I try to remember when I'm seeing someone who's being evaluated for immune deficiency. Oftentimes we'll see someone whose IgG may be a touch low, but they have never had an infection that needed to be treated with an antibiotic, which is certainly the first step to actually being diagnosed with an immune deficiency. It's not necessarily to say that their immune deficiency is just now starting and they may have infections to come in the future, but I don't think we can lose sight of the fact that that is the first thing to look for. Second thing to look for is in immune deficiency, typically not 100%, the infections are going to be in more than one spot. So if you have someone who's having recurrent sinus infections over and over and over, the first thing I would think about is an anatomic problem. Similarly, if a child came in and they were having repeated ear infections and that was the only place they were having infections, and the first thing that would come to mind to me would be an anatomic issue. Now, if the infection is in more than one spot, so they're having recurrent sinus infections and they've been hospitalized with a pneumonia, that's when my suspicion is piqued for an immune deficiency. I also think it's important to remember that immune deficiency is not only associated with increased infections, but these patients have an increased susceptibility to cancer and autoimmunity. And in the current age of having a pretty nice treatment, immunoglobulin replacement for many immune deficiencies and bone marrow transplant, many of our patients are actually dying of other manifestations of the immune system like autoimmunity and cancer. So it's very important to keep in mind that the immune system not only fights infections, but it fights cancer and it maintains a homeostasis in the body, preventing autoimmunity. The immune system's not there, those things are going to run rampant as well. Okay, so in evaluating cellular immunity, both quantitative and qualitative analysis must be considered. Defects in innate immunity are a little trickier and must be investigated individually. So the goal for today is to go through some of the more common innate and cellular defects. The first of which is chronic granulomatous disease, which we have seen an incredible amount of here at Children's Mercy in the past couple of years.
We're having an epidemic of it.
It is almost an epidemic of CGD.
What that is.
It is estimated that there is between 1 in 200,000 to 1 in a million cases, or 1 in 200,000, 1 in 1 million live births in the U.S. are a child with chronic granulomatous disease. 2/3 of all diagnosed cases are X-linked, and about 1/3 are autosomal recessive from different causes. So the main defect in CGD is that the cells cannot generate superoxides to kill the phagocytosed organisms. Now this is one of very few immune deficiencies that can be diagnosed into adulthood. So the phenotype is drastically different between individuals. Some have a very severe defect that will be fatal in their early years. Some won't be diagnosed. I think there has been cases diagnosed in the 40s and 50s when they develop a granulomatous abscess for the first time.
I think that's just a function of good luck that they've gone so long.
No, I think it more what their defect is, so that they...
Some defects are more severe than others.
Yeah, so they have some function, but just maybe not a lot of function. So the mutations occur in the proteins of the phagocyte oxidative enzyme complex, which we call FOX. So the X-linked CGD defect is the 91 kilodalton alpha subunit of cytochrome B558, which we know as FOX91. So X-linked is FOX91. And then the autosomal recessive forms are defects in FOX47, 67, and 22. So what are these things? So here is the NADPH oxidative complex. So on the cell membrane, you have your FOX91. And so remember, this is the component that if there's a genetic defect, you get the X-linked version. And then 22, 67, and 47, all these parts associate with each other to generate the ability for superoxides to form intracellularly. So if we take a step back and look out, here's your cell membrane. Here is a microbe that is getting bound and engulfed into, say, your macrophage, into your phagocyte. It's engulfed into a phagosome, which then needs to bind to a lysosome. So you have a phagolysosome. Here on the phagolysosome is the NADPH oxidase, or the phagocyte oxidase. And this is where the defect is, and this is what helps generate the peroxides, the reactive oxygen species that's actually going to kill this microbe that's been engulfed and now sitting in the phagolysosome. So infections that are associated with CGD are typically catalase-producing intracellular bacteria and fungi, such as these listed. So the granulomas, which is a quintessential phenotype of CGD, result when the T cells activate after the failure of the phagocytes to degrade the inflammatory mediators. So, of course, whenever you hit the stalemate of T cell activation and microbial degradation, you're going to get granuloma formation. So diagnosis I'm going to talk about in a second, but then treatment is possible. It's definitely bone marrow transplant. It's the way to go, and then of course, just increasing use of interferon gamma, which is thought to work by enhancing transcription of the FOX91 gene.
Does it actually do that, or is that just sort of a
I don't know that we know that.
So then the thing is that FOX91 is that X-link, which means that the person who gets it doesn't actually have a functioning copy. So enhancing transcription of a non-functioning gene, how does that help?
And I was talking to Dr. Rosenwasser about this too, and he was saying all the studies show there's no increase in oxidative burst when you give interferon gamma, so no one's 100%. I mean, like, the studies show an improvement in morbidity, but not in anything subjective that you can measure about the disease.
So this may be wishful thinking, but or it might be true. But we all always have to keep an open mind.
Yes, still, yeah, a disease in progress. All these diseases are waiting for better treatments. Okay, so how do we diagnose? So how the diagnosis used to be made by nitroblue tetrazolium, which was probably Dr. Fortman has used.
I used to do it.
And based on the same idea, but you put a dye into the cell, and then when the oxidative burst happens, the dye changes color. And that you just look under a microscopy, correct?
Yep.
And see a color change. So now we use something a little bit more sophisticated, maybe certainly more expensive, with flow cytometry, where we use dihydrorhodamine as a dye in the cell. And then we put it through the flow cytometer, and we get something that looks like this. So this would be a normal patient. And here is, you're going to have to kind of, so they overlaid two graphs, so this is not exactly labeled correctly. But in a patient who you've put dye into their cells and then not stimulated their cells, you're going to get a peak of the dye right here at, what is this, about, not quite 110, 20 or so. Okay, but then if you stimulated the cells, and in this case I think they used PHA to stimulate the cells, the dye is going to reduce, and the color is going to show with a different fluorescent intensity. So here we're about 1,000 to 2,000, let's see, 1, 2, 3, 2,500 or so, is that right? So there's quite a bit of difference and quite a bit of shift in the dye. Now, in a patient who has an X-linked version, if you stimulate their cells, they get almost no reduction in dye whatsoever. So it does not change very much. It shifts ever so slightly, but for the most part, they have absolutely no oxidative burst. This one is an example of a female carrier who's going to have, so this is X-linked, some cells that work and some don't. So some are going to fully reduce and you can get an equivalent fluorescent intensity in the ones that have reduced, but then you're going to get the second peak of the cells in sort of a lionized way that aren't going to work. So you get this double peak in the mom who's probably not going to be symptomatic at all. Okay, so this is the same thing, some more examples. So instead of overlaying two graphs, like in this example, they've separated the two graphs so you're seeing them side by side instead of on top of each other. So this is a normal individual who's had dihydrotamine put into their cells and unstimulated. If it's stimulated, you get a move in the fluorescent intensity over to the right here, quite a bit, very clear. In an X-linked patient, unstimulated, it's very much the same as when their cells have been stimulated, so it has virtually no oxidative burst whatsoever. The dye does not change at all. In the X-linked carrier, again, you're going to get two peaks, some of the cells that don't work at all, and then some that are near normal. This individual is likely not going to have a phenotypic disease. Autosomal recessive, however, many times they are going to have some ability to reduce the dihydrotamine, but not normal. So here they are unstimulated. Here they get some shift to the right here, but they're not quite normal. A lot of times this peak is, let's see if I can look at the scale. A lot of times this peak is much lower. Oh, it's not apparently obvious from this, how they have the scale set up here. So this peak is much lower and shifted to the left compared to what a normal individual would be. However, there are some with autosomal recessive forms that may be just as severe as an X-linked form, where they're going to get very little reduction whatsoever. So they label here that the patient was actually, after they had their dihydrotamine, their oxidative burst, they were initially thought to be X-linked, but on genetic testing they were recategorized.
So would the autosomal recessives be the ones who get diagnosed when they're in their 40s and 50s?
Yeah, exactly.
Are there particular mutations that are autosomal recessive that look like the X-link compared to the other ones?
I don't know which ones are.
But I thought you would rather go by the so you always do the parents with the patients. So if you do mothers and if you don't find the carrier state, that automatically tells you, you know, it's not.
Well, it could be a new mutation, too.
Yeah, I would, in CGD, when there's good genetic testing available, I think that's always the way to go for immune deficiency.
Right. Right, we always go for it, but
You
we
get the
always
sequence.
go like for it.
Yeah, right.
Okay. So,
Would I always get it in the mother as well? Is that what you're asking?
yeah, we do it here, I believe, right?
Yeah.
Here we always get it for the mother. But does, like what I'm trying to say is that pattern specifically where you would say that's autosomal recessive, or you can't really tell if it's X-linked recessive or recessive from the...
Well, I think most of the time, you know, this pattern is going to be X-linked, but obviously there's going to be some exceptions to the rule. Like in this case, it's initially thought to be X-linked, but in genetic testing they found otherwise. So it's certainly not 100%.
Well, look, if you saw something like that, that would clearly prompt you to take a much closer look at what's really going on. So you'll figure it out.
Right.
It won't fool you.
And here we, sorry, go ahead.
From what I read, it has to do with the mutation. So some of the X-links can actually have oxidative burst activity depending on where the mutation is. If it's a sense or nonsense mutation, if they've knocked out the entire gene. I think actually the earlier on you have the mutation in the gene, the more residual oxidative burst you have. The later on you have, I guess, the more functional protein you're dealing with in terms of the gene. So it depends on where the mutation is. The patient I had that was also recessive that just got transplanted looked like the bottle.
Yeah,
It was a girl, so we knew it was recessive.
Mine too. Mine looked like that.
It was autosomal recessive.
Yeah. Yes, but yeah, I didn't even think about that would be.
I doubt they'd throw you anything like this on board. Maybe, but I doubt it. I bet for autosomal recessive they'll want
I
you to
bet
pick
they'll
out
give
those.
you one of the top A, B, or C,
Yeah, the carriers.
Yeah.
or D, but
Yeah, I think I had something
they
like
might throw a
that.
D at you.
Unless they give you E and they tell you it's a girl, then you know it's
Right.
probably a woman.
That'd
Yeah.
be too easy. Though. Well, I guess it wouldn't. It would make it tricky a little bit because you look at that and say,
That's excellent, but if you look at it, it's a girl.
under a stress moment, it may throw you for a loop. Anyway, is there, where's the receiver for this? It's not.
Hmm?
Dr. Poyle, where's the receiver for this?
Oh, is it not?
It's not picking up very well.
Oh, here it is. Yeah, obviously none of us actually have first-hand knowledge about what anybody from the board's listening. We don't actually know we're discussing, but these are good guesses.
We just like to guess what is the trickiest thing possible.
Yes, because you guys, you board people are really
Tricky with
tricky.
that.
You're tricky people.
All right, so I included this just so you could see one more way that it could be shown to you. So these are histograms where you're looking at the fluorescent intensity versus the count of number of cells. Here, however, you're looking at a scattergram. So this first one, you're looking at forward scatter versus side scatter. So forward scatter is going to look at the size of the cell. Side scatter is looking at the granularity. Excuse me. So granulocytes are obviously going to be very granular, so they're going to sort of be up high here.
Mm-hmm.
Okay, so if you have your granulocyte in a normal individual, and now they're changing, it's always important to look at both the axes. This is what it took me a long time, and when I was actually where you guys are, I was not good at looking at the axes of flow cytometry, but they tell you a lot. So you'll notice that they switched from side scatter to forward scatter to fluorescent intensity versus side scatter. So you're going to still see your granulocytes are going to be high because they're granular. Side scatter measures granularity, which I would 100% know for boards. And then it changes to fluorescence. So here they have fluorescence, and then on a normal oxidative burst, the fluorescence intensity is going to change in a normal individual. So it's just going to shift here to the right. They've just gated out the other cells to make it clearer in this one. The axes of these two are not the same. They could show it, any way.
So the top all unstimulated and the bottom all stimulated?
Correct. So these are unstimulated and these are all stimulated.
So the one on the left doesn't move to the right. The bottom
The bottom left doesn't.
Yeah.
Yeah.
This one right here. Yeah.
Yeah. It moves a little bit.
Oh, so okay. So this is an overlay of here. So here's the side scatter, forward scatter. So these are just picking out the granulocytes here.
Mm.
So these are totally different graphs. This is looking at the fluorescence intensity in here, and here's unstimulated, and they stimulate.
Oh, so it's
this
up
way.
and down. Yeah.
Yes, correct. And now this is the same thing. They just gated out all these extraneous cells to make it
So that's
clear
normal.
picture. Okay. So this is a normal individual. So an X-linked chronic granulocyte, same thing. So this first one is side scatter versus forward scatter. So they're actually just picking out the granulocytes. So side scatter versus forward scatter. Whenever you see that put up, it's really just a good way to pick out the cells you're looking for. So lymphocyte populations are usually sort of down low and to the right a little bit. Granulocytes are up here. They've picked them out. But now they've changed it. So this is side scatter, so we know where the granulocytes are up high. And then the fluorescence intensity, it doesn't reduce this from here to here. You don't see this granulocyte shift over to a different fluorescence intensity. So the other one, it went from here over here, but here it doesn't shift at all.
And then what's the
And then this is just a cleaner look. They've gated out all these other cells to
back? Okay.
look clearer. All right. So you feel comfortable if you saw it as a histogram shifting or as a scatter plot shifting, but where you're looking for the shifts. Pay attention to your axes in flow cytometry for sure, for sure. It's going to help you on the boards. Know what forward scatter and side scatter is. I can almost guarantee you that will appear on the boards.
And they're not going to show you forward scatter in this case because you're not worried about the size. You're more worried about the granularity.
They may very well show you something like this pattern of 3. So,
I mean, not like you're not looking at fluorescence versus forward scatter. I mean, you're not going to look at those two in comparison, right?
Fluorescence versus forward
Forward
scatter.
scatter.
This is
Side.
I'll show you.
Okay.
Yeah. Because granulocytes are granular.
Granular, and that's what you're looking for.
The
You're not looking
granularity.
at the size.
Yeah, exactly. All right. Chediak Higashi syndrome, another autosomal recessive syndrome. It's known for pyogenic infection associated with partial oculocutaneous albinism. nerve defects, platelet disorder, and the defect is in the LIST protein. So LIST stands for lysosomal trafficking regulator. So what happens is giant lysosomes form during cell maturation, and we're going to take a closer look at that in a second. And then most patients who have not undergone transplants come to an accelerated phase of Chediak Higashi by age 10 or so. This accelerated phase is sort of a lymphoma-like stage, and is thought to, it may just be hemophagocytic lymphohistiocytosis, so an HLH syndrome. Okay, so in Chediak Higashi, what's happening, so we saw this before, the microbe is being taken into the phagosome of the macrophage. Here you have your lysosome, and with the defect in the LIST protein, you get failure of fusion of the phagosome and the lysosome. So your lysosomes know that they need to work, but they can't work, so they just get bigger and bigger and bigger, so you get giant lysosomes that can actually be seen on microscopy. So you can actually never get to this oxidative burst phase because you don't have phagolysosomes. So diagnosis is typically made on peripheral smear, often when just a normal CBC is sent to the child who's had recurrent infections, and the treatment is bone marrow transplant. Here is a microscopy showing some of the giant lysosomes that can be clearly seen just by light microscopy. So you get failure of fusion of the lysosomes and the phagosomes.
So that'll come on the CBC report, giant lysosomes seen?
Yes, and I've actually only, this is by 1 or 2 individuals of Chediak Higashi, and I ordered a peripheral smear on them first that came back perfectly normal. I did not pursue it beyond that.
So if you don't see those lysosomes, they don't have it? It's a pretty sensitive test?
Oh, boy. I'm not going to commit to that.
Okay, if they do have it, it's great. If they don't have it, then maybe.
If your clinical suspicion is very high, I mean, if someone came in with Leukocyte albinism and they had, you know, recurrent infections and this was normal, I would still send the LIST gene, especially in the age where genetic testing is becoming very, very easy.
Okay.
I actually did this just for fun on one of my patients I suspected who had very, very, very blonde features. This is not a very good test, and it's shown to not be a very good test, but it's still in the literature that patients who have this albinism, they have these melanocytes that are in sort of this granular pattern in their hair, as opposed to someone who has normal hair, so normal brown hair is going to have these discs that very nicely go in the middle. Normal blonde hair, you're likely not going to see anything. That's going to be completely absent. Normal black hair is going to actually just still look completely black under a microscope. If anyone wants to do this, Dr. Barnes actually helped me do this up in his lab, and I'm sure to be absolutely willing to help you as well. It may be worth taking just different colors hair to look and see what normal hair looks like. Chediak Higashi hair is going to have these granular melanocytes. There's going to be no good pattern to them.
Is that because the melanocytes can't fuse together to form the larger ones?
Now, I don't know actually what LIST has to do with melanocytes, but probably did before I took the course. That's too long ago now, sadly.
Defective melanosome formation.
Okay, next, innate defect, leukocyte adhesion defect. So leukocyte adhesion defect is also autosomal recessive, results in recurrent bacterial and fungal infections, impaired wound healing. So these are typically diagnosed very young. These children, this is what we always think of with delayed shedding of the cord. Their white count on CBC is always high, whether they are clinically appear to be infected or not. The mutation is in CD18, the beta-2 integrins, which affects neutrophils, NK cells, and T cells. So remember, this is a defect in the integrin, but some CD18 is associated with all the CD11s, A, B, C, and D, and a couple of those are also known as complement receptors. So remember, I think this is a potential place where they will try to trick you on all these CD markers that have different names, because we like to know that an LAD2 is associated with CD18 defect, but better, something that would be a trickier question would be something along the lines of, you know, what complement receptors are lost in LAD1, for example. Okay, So what's happening? So here you have your leukocyte. It has its integrins and selectins. Remember to stop and roll and actually get into where the infection is. So if you have chemokines that are being produced because there's an active infection going on here, from, say, the macrophages with the microbes, as the leukocytes are going by in the blood, they're going to sense this, and their selectins are going to slow them down. It's going to start to roll across the endothelium, and then eventually the integrins are going to bind, and then the cell is going to slip through the endothelium into the site of infection. If they don't have integrins, though, these leukocytes may slow down, but then they're just going to pass on by. So your body's going to know that it needs to be making leukocytes. Your white blood cell count is going to be very high because there's going to be lots of white blood cells in the blood vessels. They just can't get anywhere. They can't exit out of the blood vessels to the places they need outside of the vessels. There's, of course, also LAD type 2, which is a mutation in the fucose transporter gene, and it is an absence of the silyl Lewis X that's required for binding of E-selectin and P-selectin. Again, this can be diagnosed by flow cytometry, although this would be a send-out for us. It's not something that we can do in-house. So instead of the integrins, which actually stop the leukocyte, it's very similar. It's just the selectin binding that you're not going to get. So the leukocytes aren't able to slow down. So they're actually, near the site of infection, not going to even slow down. They're just going to zip on by. And they're not going to be able to get to the site of infection. There's also LAD type 3 in the literature. There's actually a couple different defects that are sort of lumped into an LAD type 3 defect, but a similar phenotype. Okay, so TLR signaling defects result in immune deficiency, and some of them with ectodermal dysplasia with immune deficiency. Excuse me. So there has been identified defects in much of the TLR signaling cascade, and sort of depending on where it is going to dictate where the defect is. Okay, so NEMO and I-kappa-B are going to have pyogenic infections with mycobacterial infections. If we look at the signaling cascade, NEMO and I-kappa-B are going to be fairly downstream. So it's going to affect a lot of the TLR signaling, and it's going to affect this NF-kappa-B, leading to infection. Now, MyD88 and IRAK4 are higher upstream. So MyD88 and IRAK4 are up here. So remember, TLR4 and TLR3 can signal independent of MyD88. All of them signal through NEMO, though, so this phenotypes can be slightly different because there are going to be a couple of TLRs that are unaffected. So UNC93B is associated with TLR7 and 9, and is associated with HSV similarly. So remember, 3, 7, 8, 9, these are the TLRs that are intracellular. All of these, if they're knocked out, are going to be associated with HSV infection. So here's your intracellular 3, 7, 9. So it's 7 and 9 is associated with the UNC, so they're not going to work. And then 3 is defect, and just 3 also is going to have the same phenotype, but they're all sort of over in the same part of the pathway. TLR4 is sort of all on its own. It's been associated with Neisseria sepsis. All right. Any questions about the innate defects? So let's move on to the cellular stuff. So whenever you're thinking of a cellular defect, and this is certainly what we work up the most, you always want to both quantitate and qualitate the cells. So quantitative analysis can be done by a flow cytometry. So T cells can be identified by the T cell receptor, or part of the T cell receptor, which is CD3. And of course, for T cells, we can look at subtypes, CD4 and CD8. B cells, we want to look at things that are associated with the B cell receptor, like CD19, 20, 21, are all exclusively on B cells. We can pick out B cells by flow cytometry. B cells can also be quantitated by their product, which is immunoglobulin. That's special for B cells and a different way that we can quantitate B cells. Qualitative analysis, so we don't want to know if they just have a good number of cells. We want to know if the cells work well. We want to qualitate them. So we can use tests like mitogen and antigen tests. So to qualitate if a cell works, a mitogen is something from nature. It's usually just something that's found in a plant that we can exploit and force a cell into mitosis. So mitogen is something that forces a cell into mitosis. So it will start to divide if it sees a mitogen. If we see a cell divide, we know it's capable of dividing, and that gives us some information about the qualitative function of the cell. So things that can do this would be PHA, CON-A, pokeweed, mitogen. So if a cell has already seen an antigen, it's going to have some memory, and then an antigen can force a cell into mitosis. So we can use antigen stimulation for things like tetanus and Candida. So obviously we don't vaccinate against Candida, so even, I think it's by age 3, I forget what it is, I think it's less than 50% of children are going to be able to respond to Candida. So this one is variable when kids are going to pick up the ability to have memory to Candida. And then of course for B cells, we can in particular look at their response to vaccines. So we look at an infection we know we've had, which would be a vaccine, and we look to see if we've made an immunoglobulin specific for that vaccine. So it's one more qualitative analysis we can do when we're looking at cellular immunodeficiencies. Okay, so severe combined immunodeficiency affects both humoral and cell-mediated immunity, but the one thing in common is that T cells are always infected. But you remember, in the T cell reaction in the lymph node, a T cell has to be stimulated first for the B cell to start working. So even if you have a phenotype that is a T negative, B positive phenotype, it's going to be a severe combined immune deficiency. It's combined because the B cells can't work because there's no T cells there to stimulate them, as opposed to something that would be T positive and B negative, like frutins. It's not combined. The T cells can function independently of the B cells. Okay, so 50% of SCID is X-linked. It's T negative, B positive, NK negative. What's the main mutation? It's in the gene encoding the common gamma chain. So the common gamma chain is on the receptors, the cytokine receptors, for IL-2, 4, 7, 9, 15, 21. I would commit these to memory, 2, 4, 7, 9, 15, 21. So what's responsible for this phenotype? IL-7 is necessary for growth of thymocytes, or T cells. So if you can't signal through IL-7, then you have no T cells. Similarly, IL-15 is necessary growth factor for NK cells. So if you have no IL-15, you have no NK. So if you have no 2, 4, 7, 9, 15, 21, all because of mutation in this one chain that is on the cytokine receptors for these cytokines, you're not going to get growth of any T cells or NK cells. So the phenotype for X-linked common gamma chain SCID is T negative, B positive, NK negative. This is from a BOS, and this shows the common gamma chain family cytokine receptors. Let's see, 2, 4, 7, 9, 15, 21. I don't think this 27 is actually still listed anymore. Okay. So there are other autosomal recessive forms that are going to have the same phenotype, T negative, B positive, NK negative. But what are you going to look for? It's going to be the same thing. It's going to be when IL-7, it's going to be when T cell and NK cell signaling is affected, but B cell is not. So JAK3, so remember cytokines signal through the JAK-STAT pathway. So the common gamma chain is associated with a JAK called JAK3. So here's your cytokine receptor, JAK-STAT. When it's the common gamma chain, it's called JAK3. So it's going to be a very similar phenotype to X-linked SCID, because you're going to wipe out your 7 and you're going to wipe out your 15.
So instead of getting the receptor, it gets the signaling pathway that's on past the receptor?
Exactly. Exactly. It's just one step farther down the cascade. The other one that is responsible for this is CD45. the leukocyte common antigen. So remember, when do we use CD45, RA, and RO?
For my memory and
Exactly. T cells, right. This is actually what I could quickly find on Google today to demonstrate the CD45, although I still don't think it has a great explanation of how it works in the T cell pathway, but we do know it as a differentiator between naive and memory T cells. Okay, so T negative, B positive, NK positive. So these are going to be things that exclusively affect T cell signaling. They're not going to affect B and NK. So remember, I already talked about that the reason the T's are down in the common gamma chain is because of the effect of IL-7. So if it's IL-7 receptor exclusively that's affected, it's just going to be T cells down. So it's going to be T negative, B positive, NK positive. Similarly, CD3, the different components, epsilon or delta components of CD3. Remember, CD3 is just associated with the T cell receptor, so it's going to be exclusively T cells that are affected. T negative, B positive, NK positive. I think I just put in this to demonstrate to CD3, but I think we can pass that up. Okay, so T negative, B negative, NK negative. So everything is dead. And the only thing that kills everything is its toxic accumulation. So ADA, adenosine deaminase, purine nucleotide phosphorylase, or reticular dysgenesis, which is actually going to affect the mitochondria, which is in all three types of cells. All of these things are going to cause T negative, B negative, NK negative. So it's a broader stroke of cellular killing for these, a less specific receptor, nothing as specific as the receptor, I should say, that would kill all your cells. All right, and last one, T negative, B negative, NK positive. So these are going to affect the cells that recombine. So these are going to be parts of the recombination phase. You're going to get T negative, B negative, because remember, NK cells do not recombine. Only T and B's recombine. So it's going to be things like RAG, Artemis, ligase 4. Partial defect in any of these is going to be an Omen syndrome. Okay, so if we look back from the BAS text about how we have our recombination event, where you get your your TREC basically that's spliced out. This is going to start using RAG, and then you're going to get opening of the hairpin using Artemis, and you're going to get repair using the rest of these, like ligase 4. Any of these things involved in this what's TREC stand for? T
receptor excision circles.
Thank you. Is going to give you a T negative, B negative, NK positive, because T cells and B cells undergo this rearrangement, but NK cells don't. All right. So that is just the way I choose to think about the different SCIDs and trying to remember what defect is going to cause what SCID phenotype. Obviously, it's not the perfect way, so
No,
choose your own adventure.
It's very logical, though. Yeah.
Okay. Next, quickly, I want to mention DiGeorge Syndrome, which is a deletion from 22q11, causes malformation of the third and fourth pharyngeal pouches with very varying degrees of defects. In fact, I just recently saw a child who was 13 who was just diagnosed, who is really a very healthy child, but he did have some syndromic features. I think it was an eye problem that he had that was known to be associated with DiGeorge, and that's why he was tested. It's also known as velocardiofacial syndrome. So if you have athymia, no thymus at all, then you actually have a form of severe combined immune deficiency. It's complete DiGeorge. It's a T negative, B positive, NK positive form of SCID. So, of course, as immunologists, the defect that we are most concerned about is the lack of thymus, or at least a partial lack of thymus. But you can also have defects in the parathyroid glands, heart, large vessels, and, of course, facial deformities. The treatment for complete DiGeorge is thymic transplant, which is done at Duke on protocol, and has been doing very well on protocol. but most of the time, incomplete DiGeorge, or those who have at least a partial thymus, many times will actually not need any immune support at all. Some will start sluggish, get better. Some portion of those will actually, their immune system will stop working later on into adolescence. So it's very variable, and to me, it's a little bit tricky in these kids when to pull the trigger for giving immunoglobulin support, but you really need to look at their infections and whether you think their infections are because of a facial deformity or a true immune defect. But this is probably the one syndrome that we go round and round and round and round and round about it most within our own section about what to do at each stage of the game. So some other things worth mentioning that were then back of a boss, defects in MHC expression like bare lymphocyte syndrome, where you have MHC class 2, a lack of MHC class 2 expression, and MHC class 1 deficiency. So MHC class 1 deficiency is when you have a mutation in things that are specific for MHC class 1, like TAP. Defect in T-cell signaling we talked about a little bit. What's called alterage. I did not spend too much time on today. X-linked lymphoproliferative. Dr. Argo can probably teach us all about at this point because of the patient she has been working up. And then I mentioned briefly HLH, which can result from things like perforin defects, but I'm sort of choosing to, for the sake of time, gloss over some of these rare ones. Not to say you don't need to know them. Okay, antibody defects. So again, we need to quantitate and qualitate when you're worried about B-cell defects. So B-cells, by flow cytometry, you look for things like CD19, 20, and 21, and then you can quantitate the immunoglobulin. So we order levels of IgG, IgA, IgM, and IgE. There is a minimal, if any, role for subtype analysis that we know of at this time. So it's really just the IgG total level that we're quantitating. So to qualitate B cells, you can get mitogens, of course, but we can also exploit the fact that they have a cellular product, which is immunoglobulin. So we look to see if you actually have the ability to respond to a vaccine, and there is a difference between your ability to respond to protein antigens and carbohydrate antigens, and I think this is where the B-cell stuff gets very tricky. So if someone has no response to protein antigens, obviously there is a problem. If someone has a very good response to protein antigens, but a sluggish response to carbohydrates, this is where we can run into some problems about trying to decide what to do. Okay. So as you quantitate, if you have quantitated no B cells, no immunoglobulins, and of course if you have no immunoglobulins, you're not going to be able to detect any response to vaccines, then the X-linked version and most common cause of that, AGAM, is Bruton's, which is X-linked, which is a result of a mutation in Bruton's tyrosine kinase. And then there are autosomal recessive versions that have been found, like mu heavy chain defect, surrogate light chain defect, and blink. So what happens, this is B-cell signaling. So we have our Lin-6 pathway. Bruton's tyrosine kinase is essential for signaling at this part. CYP65 is also known as blink. So blink and BTK are at the same point. Now, if you cannot signal through the B cell is actually not going to be able to move from the pre-B cell stage to the immature B cell stage. It's actually going to arrest that pre-B cell development because it's not going to be able to signal that things are working correctly. So you actually never get to this mature B cell stage, so you're never able to quantitate B cells on flow cytometry. All right, so if you have normal B cells but then low immunoglobulins and no vaccine response, then this is hypogammaglobulinemia, and we usually, so if you would have low IgG and then one other IgA or IgM, then we'd call that common variable immune deficiency. If you have just the low IgA, then we have selective IgA deficiency. And then, of course, there are things like hyper-IgM, where you have normal B cells, but you're unable to switch from IgM and class switch to any of the others, like IgG, IgA. So you may have high IgM, you may have a near normal IgM level, but you're going to have very low IgG levels and very little specific antibody. The defects that can cause this are CD40 ligand, CD40, NEMO8, and there's lots of different defects that can cause the same syndrome. Okay, but then if you have normal B cells, normal immunoglobulins, and then no response to vaccines, then we usually call this a specific antibody deficiency. This is where it's in particular polysaccharide vaccines, where it is still individualized whether you think that the patient is going to benefit from immunoglobulin replacement. Certainly if they've been having infections consistent with an immune deficiency and they have absolutely no response to a polysaccharide vaccine, then there's probably an argument to start them. If they have a partial response to polysaccharide vaccine, they have not been having that many infections in retrospect, then this may be a candidate for someone to watch. Okay, and then what do we do when we have normal numbers of B cells, low immunoglobulin levels, but absolutely normal response to titers? I think this is what I see the most. So if they're young, then I usually call it transient hypogamma of infancy, which I typically choose to not treat with immunoglobulin replacement. I know some people do. And then I always start thinking about secondary causes of immune deficiency. So acquired things like medications that they may be on, mineral deficiencies, cancers, autoimmune disease. Certainly people who have autoimmune disease and are on therapies for autoimmune disease, I will see this a lot. This is where I really struggle to decide when someone needs to go on immunoglobulin replacement, but typically they present themselves one way or the other with multiple infections. But if you have normal numbers of B cells, good response to titers, and it's just isolated low immunoglobulin levels, make sure you're doing a very, very good workup for secondary causes of immune deficiency before you declare them primary immune deficient. And that's it.
Oh, well, whirlwind tour.
Whirlwind tour of immune deficiency.
Yeah. All right. Thank you. That was absolutely amazing. Are there any comments or questions about this presentation? Anybody? No, I guess our brains are kind of full, so not room for much more. If we asked a question, we'd have to have room to put the answers in. Anyway, thank you, Dr. Ciaccio. Brad, did you want to have the final word as you usually do? Go ahead, Brad.
Now, just a quick question. Oh, it bugs me with CGD. That involves INOS. That's inducible nitric oxide synthase, not the constitutive. Another thing that inhibits INOS is nicotine. So smokers essentially should have a CDG or CGD of the lungs. Is there any evidence for that?
Do you think that's why they tend to get more lung infections? Because they're inhibiting their oxidative burst?
Yeah.
It's a good thought, but they, what I see is typically more pneumonias and obviously cancer from a relative immune deficiency, but not exactly granulomatous disease.
Well, they all in chronic lungs usually have a lot of neutrophils in them that, for some reason, that you know, when they're well, any of those things have a lot of neutrophils in them, and that's why I thought, well, okay, that could be a possibility.
Yeah, there are other things in tobacco smoke too that can cause a more generalized relative immune deficiency in that location. So it may be that there is a relative, you know, decrease in INOS, but then the T cells aren't able to actually form a granuloma because they're being inhibited too by different things like acrolein, a particular chemical of interest in the tobacco smoke.
Yeah. Okay. Just a thought. Thanks.
In adult patients, I bet the most immune deficiency we see is alcoholics and smokers. So we'll see smokers come in all the time. They have current sinus infections, pneumonias, and alcoholics will have nutrient defects leading to cellulitis when they get admitted. currently, that they've wiped out their immune system with their habit.
Right. Well, we're going to have to stop there. Thanks, Brock. We're going to have to stop we're going to take about a 3-minute break while Dr. Hogarth gets set up. In the meantime, this is Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics. We'll be back in 3 minutes. This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.